Hi, everyone. Welcome to the AI and Mental Health Revolutionary Reboot or the Rise of Digital Asylum. Please mute yourself. And just a heads up, we will be recording the session, so feel free to also face mute yourself. In the chat, you should see the link to our session's Google Doc, which contains a roll call and our session agenda. We'll start off with a round of introductions from each of the panelists. The panelists will then present each of their topics, and towards the end, we'll have a group discussion where we can all, share questions and comments between the speakers, the panelists, and the participants. And at the end, we'll end with a summary. So enjoy your session.
Thank you, Anjali.
Recording
and
in progress.
Welcome, everyone. I'm so glad you're here. My name is Karis Myrick, and I'm located in Los Angeles, California. And I'm so happy to be a part of this panel with the other panelists and just want to welcome everyone. I'll be sort of playing the role of facilitator, I think, a little bit, helping us through. And recognizing that this is a global event and an international panel, I will try to do my best to speak a little slower. I've heard as an American, I speak fairly fast, so I'll try to slow it down a little bit without slowing stuff up. And really want to welcome you to this exciting panel that, at least to our knowledge, may be one of the first panels that brings together globally people with lived experience of a mental health issue, as well as people of color. And you don't see this very often, so I think you'll be very interested to hear the various things that we're going to be talking about relative to the use of digital technologies in mental health, particularly those that are using AI or digital phenotyping or things like that. So I will say that because we're coming from all different places and walks of life, we might use different language in how we talk about mental health distress. There's a lot of politics, of course, around mental health. So you may hear some of us use terms like peers, P-E-E-R-S, peers, service users, consumers, people with lived experience, to all refer to the people who have been given a diagnosis of a mental health condition. And those folks may also use terms like trauma, distress, psych survivor, things like that. So as we talk, I'm hoping if you have any question about any of the terminology that any of us are using, please use your chat and, also tell us what terms you're hearing out there, where you're from. So we really wanted to bring this group together because we wanted to look at the rights focus related to use of technology, especially in mental health, and the viewpoints of people with lived experience in either their participation in some of this work and or how they are perceiving the work that sometimes is imposed on them as far as the different types of technologies. So we were brought together, I don't know, about a year or so ago by Pierce Gooding, who is also on this panel. We have Pierce Gooding, who is in Australia. We have Kelechi Ubozo, who is in Northern California. And we have Lydia Brown, who is in, I was going to say New York, Washington, D.C. So that's our panel. And each one of us will be presenting on a different aspect of this idea of AI and is it a revolutionary reboot or the rise of the digital asylum? Because MozFest is focused on AI and wellness, of course, mental health fits really, really well right in here. A lot of times people might not consider the ideas related to mental health and people who are receiving mental health services. So we're very excited that we get to talk about this from our experience, either using some of these technologies, helping people develop these technologies, or just interrogating the process of the implementation or development of these technologies with vendors, within systems of care, and the like. So one of the things that I also wanted to bring up is that, when I'm speaking for myself, I'll let you all know that, this is Karis Myrick's view. This is not the view of the world. This may not be based on science, anything like that. That really, this is my personal experience of, what I've been going through relative to understanding the use of AI and technologies in mental health, and then partnering with others to ensure that the people with lived experience who are subjugated or subjected to these technologies have the information that they need in order to, when they can, because sometimes like the technology has left the station, be able to make decisions about using different types of apps and technology in their mental health recovery and wellness. So I'll go ahead and first of all, I hope everybody can type in, say hello, say where you're from. I feel like I'm looking at a blank screen. I don't see everybody, so it would be nice to know who everybody is, and I'm sure everybody would like to know who you all are too, and just say kind of hello and where you're from and your interest in this topic. That's also in the Google Docs as well. So I'll go ahead and start if Pierce, if you could put up my slides. And the reason that I use slides, I know this is not, the type of event where one would generally use slides. I am extremely visual. So this will help me stay on track, on topic, know what it is I'm going to say, know what it is I'm going to say next. But really, I do want it to also be engaging and to invite people into the conversation. So when I was first introduced to digital technology, it was years and years and years ago. I might have had an iPhone. I don't even know if I even had a phone. I probably did. Probably one of the first iPhones or something like that. And, everybody said, oh, there's an app for that. And so as things progressed, we hear interesting terminology like AI, and in mental health, the latest thing is digital phenotyping. And it sounds really cool. It sounds really like, oh, wow, that's like deep. Like I'm really kind of the smartest guy in the room, if I could say that term. But the reality is, what does it mean, right? And so what we were finding is that a lot of times we have to say, oh, there's a digital what for that? Like, what do you call it? You can go to the next slide. So, so one of the things when we start looking at the use of technology in mental health, whether it be digital phenotyping, AI, any type of technology, and people are really, really interested in using technology in mental health, we start to see this rise, and this is all US, of the evolution of technology and its adoption and usage from 2000 to 2016. And I think this is why people are really excited about using what people have apparently have ready access to, and generally use the words like, oh, it's ubiquitous. Look at the use of the internet, and having broadband or using social media, may have one or more smartphones, or you own a tablet. It looks like that's a really nice sweet spot as far as a possibility of providing, using technology as a means to access. Okay, next slide. But when we kind of break it down, and again, this is looking at US data, we start to see some really interesting disparities when you're looking at people who are in private care versus people who are in public care. So in private care, for example, you can see the black line is, and then it's across age. So you can see the percentage, and then the age for things like smartphone ownership, downloading an app, using a mental health app, and then if you've ever just used one, and then currently using one. And you can kind of see where disparities start to happen in the private side. As people become older, it starts to be like, well, they may not have a smartphone, they may not download apps. And as they get older, it's like, I didn't even use a mental health app, let alone currently using one. So then when you pop into the public sector, and this is our public mental health, you start to see some really, really interesting disparities about, well, who owns a smartphone? Who's ever downloaded an app? Who's ever used a mental health app, and then who's currently using a mental health app. So this is kind of really interesting because we also want to look at, well, who are those people in those demographics. And generally for folks who are in public mental health in the US, it can range, across sort of socioeconomically. It tends to, of course, be people who are in lower socioeconomic realm. But when we look at race and ethnicity, then you start to also see a lot of differences about who has access to technology and how they might be using that technology. Next slide. So one of the things that kind of has come up in public mental health in California, and Kelechi will go into this a little bit further, is this idea of, and again, this is big everywhere, the idea of digital phenotyping. And digital phenotyping is basically capturing all of that stuff you do with your phone. I'm just going to make it real, like basic language, not techie language, to start to get some baseline about certain patterns, and then use those patterns to be predictive of how your mental health may be doing. Next slide. So as you see, it can capture certain things supposedly around sort of your symptoms, your behaviors, cognition, physiology, environment, and social connection. And then what digital phenotyping does, which is a little bit different, is it analyzes that to make these predictions so that then it can start to provide suggestions for interventions to help the person based on where they are with that prediction. So now remember I said that there's going to be some disparities in what happens, who owns what. So a lot of this data that's collected is considered to be like these big data sets in which you're getting kind of like a public health perspective. But if you're looking at data that goes into this little black box, if you don't understand exactly what that analysis is, like how did it happen, what is it predicting, if there are swaths of people who do not have access to the technology and whose data is not taken into consideration in these large data sets, then really what is it predictive of and for whom? And those started to be some of the questions that were being asked, basically around the use of digital phenotyping in public mental health. Next slide. So as we started to hear these terms, it was the first time we're hearing these terms. We don't know what these terms mean. Digital phenotyping, who runs around saying that? And I had to learn how to pronounce it, right? So anyway, so there's a lot in the popular press that actually looks at some of the research. So that's the stuff we can get our hands on probably more easily kind of in the public, is this popular press. What can they tell us anything about insights into your mental health? So how the peer press understood that, and I call the peer press people with lived experience, this is basically in California, how they were understanding this information is, well, wait a minute, you're starting to collect data about me and you're going to make some predictions. Are these predictions based on any kind of evidence? And what happens with these predictions that you're making? First, are they accurate? Are they really showing that I'm in some kind of mental health distress? In the US, if somebody is in mental health distress, and let's say that the algorithm says something like, wow, this person isn't really doing well at all, they haven't picked up their phone, they haven't done this, they haven't moved, and we know they're in the public mental health system, you may need to send the police out to do a mental health check. And it's the police who comes to do your door. It's not generally, depends, but it's not generally a social worker. It's not your neighbor. It's not your mom. It's not your peer supporter. It's some stranger, usually who has some kind of power over you, that will come and respond to this distress signal that was actually shot out from the algorithm from the digital phenotyping. So there were lots of concerns about HIPAA compliance, who owns the data, what about privacy, what about security, et cetera, that started off in the peer world from the use of these kind of technologies in public mental health. Next slide. So what we really wanted as people with lived experience was to be a part of the design, part of the implementation relative to any kind of technology, because there are going to be issues around privacy and the like with any kind of technology. But clearly around this kind of work, we really wanted to have more say, so more partnership, I think it would be fair to say, more partnership and collaboration across the whole waterfront, from design, implementation, study, evaluation, redesign, and distribution. So, but what happens is the top of this graphic, I love this graphic, it's from somebody actually in Australia, and it says at the top, the guy on the left-hand side of the screen, I'd like to create a platform for survivor voices that are excluded from mainstream mental health campaigns. And then the staff say, okay, but it would have to include the survivors we already hear a lot from, meaning those folks that they're going to be people who are excluded because you don't like what they say, then you're not going to invite them to the table. The other one is, okay, but they can't be critical of services or dominant mental health narratives. Okay, well, that doesn't make a lot of sense. How do you learn and grow if you're only going to invite people to the table who will say things that you're in agreement with? The other person says, and people must communicate using formal, unemotional language, meaning speak like us or get out of the room, right? So how hard is that for somebody who's coming into a tech conversation if they're not able to pronounce words like digital phenotyping? Basically, you're not allowed at the table. So, the service user is able to certainly interpret this, reinterpret their comments as, so you want a platform for survivors that doesn't prioritize marginalized voices. You want people to be positive about services and dominant medical narratives, and you want them to say it politely during a formal meeting. And of course, the staff are like, absolutely. We can give them 10 minutes and free tea and biscuits. We like them to tell us about what color they think the wall should be painted. We really value service user involvement, which really says we don't. And it's very tokenizing and diminishing to the person. And at the end of the day, these things are going to be used by people, right? People you're trying to serve or help. And so we should be able to give feedback into those processes. Next slide. So there are lots of different ways that we tried to look at this, particularly in Los Angeles. We surveyed over 500 individuals in lots of different ways. So they could be transitional age youth, they could be people receiving services, they could be professionals and college students. And we wanted to make sure, because LA is very, very diverse with over 13 threshold languages, to ensure that we got a lot of diversity in age and also in ethnicity. So we went to colleges, particularly colleges that are known to have high Latino populations. We went to this thing called Drew League's basketball games, and Drew League's really encourages students of color to consider historically Black colleges and universities. Then we went to a lot of different events that generally people of color, you'll find tons of them. So comedy events, comedy festivals, and different type of community festivals. And you'll see that we had a large number of African American and Latino in our respondent pool, which is exactly what we wanted, because that's the highest population that we have in Los Angeles County. And this is what they told us. Next slide. So we had asked them about, well, what kind of things might you use for your mental health? Not that you're currently using, but might you use? And so you see AI is way down there compared to a lot of the other things that they were considering. Now, what's really interesting, though, is there may be AI used in some of the things that they are still interested in, but they didn't identify it that way. So, but it does help us to understand that when we were thinking digital phenotyping, they were thinking, hey, give me a guide to wellness. Hey, give me something that tracks my activity or my mood, that kind of thing. And then we also found out that many people wanted to learn, how do I even use my phone? I have a smartphone. I don't know how to use it. I don't know how to do basic mail. I don't know how to set up even to get an app off the App Store. So people needed basics before we could even move into understanding the complexities of a policy statement. Where is the policy statement? How do you read through the legal language of a policy statement? They just wanted to know, heck, how do I even use my phone? And they were telling us what they did with their phones, which is they were renting them to people, they were selling them to people, they were sharing them with people. So then we had to beg the question again, how accurate is that AI data, that digital phenotyping, if the phone is not in the hands of the intended recipient? Next slide. So we created digital health literacy curriculum. This is in the public delivering it to peers to cover those very issues. How do I use my phone? How do I do the basics? How do I download an app? How do I look at my security and privacy and setting lock codes on my phone? And this was really great because the other thing it did is it employed people with lived experience and gave them the opportunity to do things like curriculum development. The artistry is done by somebody with lived experience, and it started to have them working more and more in the tech area so that they could also start to learn about tech processes, tech language, etc. Next slide. So they created all sorts of tip sheets for the people we serve about like downloading the app. And a lot of this was around privacy and security and understanding how to look at the reviews. And then also looking at how to keep your identity private, how to look at your active digital footprint, as well as your passive digital footprint. Okay, next slide. I'm going to be mindful of a minute. So that's all I have. I just wanted to lay the groundwork of kind of what happens, again, sort of to people without people, and how, we really tried to make opportunities available for people with lived experience to learn more about this field, especially around artificial intelligence, digital phenotyping, and what happens in mental health, how to advocate for privacy, security, as well as being a part of the process and developing what it is that people need, where and how they need it, versus thinking, oh, this is really cool, digital phenotyping, how cool. Little creepy, very cool, but if it's not what I need, that might not even be really helpful when you're looking at it from a very large public health perspective. So I'm going to turn it over to Kalechi, who will be able to tell you a little bit more from her perspective. Thank you.
Thank you so much, Karis. Ooh, I think I'm echoing. Okay, it stopped, I think. So, hey, everyone, I'm Kalechi Bozo. Karis did a really great job of kind of breaking down what lived experience is and a whole bunch of things. Just as a brief introduction, I am the co-editor of We've Been Too Patient, Voices from Radical Mental Health. And that's an anthology of folks who've been labeled with a mental illness or considered patients and seriously like looking at the challenges with the biomedical model, which I will talk to you a little bit about today. I also have nearly a decade of experience working in the mental health field around peer support, advocacy, stigma reduction, and research. And I most recently worked on that digital mental health solutions project. So this is California based. It was a statewide project. And the goal of the project was to bring digital mental health solutions into the public health system. And we'll talk a little bit about that part as well. But before I do that, just want to provide some historical context about the mental health system. So when you think about people who've received a label of mental illness or even claim that identity, we have faced discrimination in the mental health system. We've been subjected to treatments, isolation, warehousing, exploitation for labor or entertainment, abuse and neglect, medical experimentation, sterilization, and loss of legal rights. And I personally, I've lost a job for disclosing when I was struggling with a mental health issue. So I think some folks think of like the mental health care system as a system that doesn't have these kind of traumatic issues baked into it, but it does. And so when you think about digital health solutions and how tech can support mental health, it's also important to remember that history and unpack it. So The other thing I want to talk a little bit about before I get into some of the lessons learned from community engagement, which is so much more interesting, is kind of breaking down what the challenges are with the biomedical model a little bit. So for those of you who don't know, the biomedical model is basically the medical framework of how most of mental health is run in this country. So the idea is that you treat an illness, you focus on modifying brain chemistry, and you focus on medication. And really the focus of treating an illness is emphasized over health because the belief is that health is the absence of disease. Now, this is problematic because it's not taking into account race, culture, environment, spirituality, trauma, or identity. And if you're treating an illness, you're not working with a person and you're not integrating that whole person into your care. Also, there's problems with self-agency. So the person who has the most expertise in this medical model framework is a psychiatrist, it's a mental health professional. It's not the person who is actually receiving the care. And what we believe is folks, and it depends, I will use I statements. What I believe is that I believe in a recovery framework, and if medication works for you, that's great. It's not to take away from psychiatry or therapy, it's that a person who has lived experience should be driving their choices and having self-agency and be a partner, not someone underneath. And that's not frankly how like many folks are treated. So thinking about this, if you take this biomedical model framework and you put it into a tech framework, sometimes it turns out into like looking like, oh, monitoring your medication or checking in on your symptoms. And you're not really looking at what does that person believe is their goals, or what they're striving for may not be the same thing that someone else believes are their goals. So I just wanted to provide a little bit of that backdrop. There's a whole book with more in it. We don't have time for that. But what I do want to tell you about is that Karis was mentioning this project with peers, and that was based in California. So I was part of this Help at Hand project, and I was a community engagement manager for a bit. And during the summer of 2019, and just a backdrop on this project, the goal of this project was to bring 3 types of digital solutions to the public mental health sphere. So that was AI and digital therapeutics, digital phenotyping, and peer support. When I got onto the project, I was met with fear. There was serious mistrust of how is someone going to use my data? What does digital phenotyping mean? I'm really afraid of this. We'll break that down a little bit more, but I thought the best thing to do was, well, why don't I spend time with stakeholders across California and hear about what their concerns are, what wellness means to them, and what they're hoping technology would do for their wellness, and a little bit about what's maybe getting in the way of their self-care. And I use technology and self-care because I couldn't always say mental illness or mental health because folks wouldn't always land with that language. But if I talked about wellness, that landed a bit more, if that makes sense. So back when we could see people in person, I spent the summer of 2019 facilitating listening sessions and spoke to over 300 stakeholders. And I'm talking, I was in rural California, I was in LA, I was in urban parts of California. We talked to young adults, older adults, trans women, people experiencing homelessness, monolingual communities, and essentially, and even more folks. And we asked them 4 questions. What's important to you in your wellness? And how are you currently using tech for your self-care? How do you hope technology could help your wellness? And what gets in the way of you using technology for your self-care? And the last question was, what kind of skills would you need building to that digital mental health literacy curriculum that Karis was talking about earlier? We knew that a really good way of engaging folks in tech was to maybe give them some idea about what their rights are, how to use certain apps, what is a data footprint, and all of those things. So we wanted to kind of find out feedback from them about what essentially would be helpful or not helpful. Okay, so I want to be careful and mindful of time. So I'm going to get into just a few takeaways. I was really shocked what people wanted for their self-care or how they were using tech for their self-care was not how I thought they were using it. They were like, oh, I'm using WhatsApp, I'm using social media. The most important thing for me is social connectivity. So when we asked people about what was helpful for their mental health, it was social connectivity. And that was surprising. When I asked about what they're doing, they also talked about Fitbit and the Calm app, or things that distress them, or YouTube and podcasts and music. So I'm thinking people are going to use mental health solutions, and they're using things that are not technically billed as mental health solutions. And then when I asked what people really wanted for their mental health, a lot of folks said, I want crisis support without law enforcement. I want to be able to get online, reach out to someone in the middle of the night if I'm struggling, and not be faced with law enforcement. And it's really important for this group to know that if you're someone with lived experience, you're Black, brown, queer, trans, and you have law enforcement called on you, there's a pretty good chance that that will not be a positive encounter. It has, folks have shown more data about how lethal those encounters can be. So that was really something that folks wanted, was actually access to other people. So I thought that was really an interesting takeaway. And another big takeaway working on this project was that when we asked people with lived experience what they wanted, it was already too late because the decisions had been made about what they were going to get. And what we needed to do was actually engage them way earlier in the process about what, with participatory frameworks of, okay, here's a solution. What do you think? What are you struggling with? What's going on with you? As opposed to, here's A, B, and C. Do you like it? Right? The user design, or do you like blue button or red button? It doesn't work. Folks really had a lot of insight about what they wanted and needed, and they weren't going to get that through this process. Last but not least, there was a huge fear that using that technology, digital phenotyping specifically, would be used to essentially track, find someone, surveil them, and involve law enforcement. And one of the digital phenotyping solutions that we were considering in the project, made some bold claims that it could prevent a mental health crisis. But in fact, there were, in some of the piloting phases, folks had a mental health crisis and it didn't catch that. So there was also distrust of, you said this could prevent something, it didn't. What is this tech claiming to do versus what is it actually doing? So I think the big takeaways for me are really evaluate if what you're building people actually need, and really involve stakeholders in the beginning and invest time in authentic community engagement. I learned a lot from that. I'm going to turn it back to Karis to tell us who's next. Sorry, I went a little over.
Oops. Thank you, Kelechi. These topics are so interesting, and we rarely get such an audience to share them with. So next, I'd like to, let's see, who is next? Lydia, would you like to go ahead and share?
This is Lydia. I use they, them pronouns. I'm a youngish East Asian person with short black hair and glasses. I'm wearing a shirt that is purple and it says LGBTQ task force on it. So I'm inadvertently repping an organization I don't actually work for because it's the shirt that I grabbed today. With me is a plant child that is partially drooping, but is definitely alive currently. And I intend for my plant child to remain alive, but intentions don't always translate into the actual results. I'm joining from the United States, and in particular, I'm joining from where I work at the Center for Democracy and Technology, where I address disability rights and algorithmic bias and discrimination for the Privacy and Data Project. But beyond that work and in informing the work that I do at CDT, I'm an advocate and a community organizer for disability justice. I'm openly mad, neurodivergent, and disabled. And I've been in this community and doing this work for more than the last 10 years. And what I want to talk a little bit about, and bridging the comments that we've already heard from both Karis and Kelechi, is about what ableism is and how saneism as a particular type of ableism, a particular manifestation of it, fits into the picture. And I think this will help to further contextualize what Kelechi was already sharing about the biomedical model, and what both Karis and Kelechi have already addressed, and what I know peers will address as we conclude, in returning and redistributing power by addressing and disrupting existing systems and structures of power. So understanding ableism begins with understanding and situating it as not merely discrimination or prejudice or bias, but understanding it as a system of power differentials and power relations. wherein people whose body minds are deemed to be healthy, whole, functional, stable, sane, strong, intelligent, and beautiful are granted enormous political, economic, cultural, and social power at the direct expense of those of us whose body minds are instead deemed to be sick, broken, defective, deficient, disordered, deviant, dependent, insane, unstable, unintelligent, or ugly. Ableism is a value system that teaches us what kinds of people ought to be allowed to exist, what kinds of body minds are valuable, worthy, and desirable, what kinds of body minds in turn are expendable and disposable. Ableism, in other words, teaches us which kinds of body minds are normal, which is always a political and arbitrary designation, and what kinds of body minds are abnormal and therefore exist only to be subjugated, contained, controlled, managed, disappeared, and prevented from coming into existence again. As a system of oppression, ableism manifests in many ways because disabled people take up space in the world in many ways. Whether or not we use the word disabled for a variety of reasons, many of which often trace to pervasive and endemic ableism itself, whether our experiences are in the world moving through the world as neurodivergent in many different possible ways of being neurodivergent, moving through the world as blind or as deaf, as people with absent limbs, as little people, as people who use mobility technologies for assistance, as people with communication disabilities. There are so many different possible ways to move through the world as disabled. So ableism takes many forms in how it impacts disabled people's lives. And one of those forms is saneism, which is sometimes also called mentalism. They mean the same thing. And it is the valuing of people whose body minds are considered to be value on arbitrarily defined norms for what constitutes healthy and sanity. And at the same time, devaluing and dehumanizing and delegitimizing the lived experiences and the mental states and the ways that brains work for those of us who are instead deemed to be crazy, mad, insane, for those of us whose brains are considered to operate outside the bounds of reality. And this shows up not just in what language it is that we use, not just in laws or policies, but also in the very values that infuse the kinds of systems that we operate within. So Kelechi was just talking about how people who have lived experience would speak about wanting access to crisis support services that didn't involve law enforcement. And so the work that I do, which is grounded in a practice of disability justice, which is also deeply connected to and rooted in and informed by the Mad Pride movement, the neurodiversity movement, and movements for self-determination, independent living, and self-advocacy in different disabled communities, understands that police are only one part of carceral systems. And carceral systems include the entire mental health and behavioral systems as they are now. Carceral systems include the foster care system, which I don't really call it that, as well as the criminal legal system. Carceral systems include our educational system because these systems are set up not only to privilege and to empower people whose body minds are deemed normal and ideal, but to literally disempower, disappear, and to ultimately prevent from existing those of us whose body minds are deemed to be disruptive, deviant, and threatening. So ableism as a system of oppression is deeply connected to, necessary for, and dependent on every other form of oppression. And disability justice helps us understand and articulate the ways that ableism is deeply connected to settler colonialism, white supremacy, racism, capitalism, patriarchal oppression, class oppression, and many other forms of oppression that exist, whether we're talking about colorism, casteism or caste-based oppression, whether we're talking about oppression based on sexuality, and any other possible form of violence. Ableism undergirds all of these systems, and it is informed by all of these systems. Even the way in which people who are thinking about more progressive or radical or revolutionary approaches to disability or mental health or to other social and cultural issues will leverage the logic and language of ableism, and particularly of saneism. When we talk about white supremacy as a mental illness, literally erasing and causing great, awfully disgusting statements, right, about the experiences of psych-disabled people of color, especially from Black and Brown and Native communities, that to call white supremacy the real mental illness, the real affliction, the real disease, leveraging the logic and the rhetoric of ableism in that way just is further evidence of the ways in which ableism is so endemic in all the spaces that we operate. So it is of no surprise to me that most conversations about technologies related to mental health in general or disability more broadly are rooted in carceral and ableist approaches to disability and to mental health. That is, technologies that exist to therapize us, to medicalize us, to pathologize us, to surveil us, and to criminalize us. Technologies that may ostensibly be for our own benefit, that is, perhaps we wish to detect if you are experiencing or about to experience a relapse of addiction or a more intensified episode of depression so that we can provide support to you. In theory, that could sound decent for like 2 seconds until you think about the implications for longer than 2 seconds. What does that mean about who has access to this data and what are they actually using it for? And is this data going to be used, because it probably is, to further mechanisms of control and destabilizing forces and surveillance in our lives, the lives of people who, especially in our communities, those who are multiply marginalized, who are at the margins of the margins, have already been subjected to hyper surveilling tactics and techniques, to hyper criminalizing processes and systems, because our whole lives are constantly considered as fodder for researchers, for therapists, for clinicians, for literally everybody except ourselves. So when I'm thinking about what conversation I want to see happening about AI and mental health, here's what I want to see happening. Not just are we consulting people with lived experience, but are the developers and the researchers listening to what people who are psych disabled, mad, neurodivergent, have mental illnesses, whatever language a particular person uses? Are you listening to what we want for ourselves and our communities? And are your technologies, the ideas that you have that are even long before you get to prototyping, when you're still at the drawing board, are those ideas actually moving us closer to the goals expressed and articulated by the people who are the most impacted and who have the most to lose, or not? It's that simple. It's not, did you consult with us at some point? Did you get our feedback? Did you ask us for our opinion? It is, are your priorities and end goals driven by the priorities that come out of our own community? Because if they're not, then your technology isn't about helping or supporting. Your technology is only at best about the appearance of helping or supporting without the substance of it. So for me, being here as a multiply marginalized disabled person, that is the point I will always make. Whether you are a policymaker or you are a researcher or developer, the question is your work directly informed by and following the lead of those who are most impacted? I will turn it back to you.
I'm going to jump in because Keris just privately messaged and said I should. I'm going to follow that up by introducing myself first. My name is Piers Gooding. I'm coming in from Melbourne, Australia, for a visual cue. I'm in an extremely drab office. I am a former Mozilla fellow, so that's how I came across a lot of the great work the Mozilla Foundation and MozFest. And I've been working on these issues for some time. It's customary here to acknowledge that I meet on the land of Wurundjeri people of the Kulin Nations and pay respect to elders past and present. Now, look, I'm going to share a slide as well. I don't know how I can follow up that extremely impassioned and really incredible account of some of the politics behind what's going on. But I'll just rush through so that we can get to questions as soon as possible. So, this is a photograph from the 1950s from the MIT Artificial Intelligence Lab of Professor Joseph Weizenbaum with what is often considered the first chatbot, Eliza, which was based on the psychoanalytical conversation script used by prominent psychoanalysts in California at the time. Interestingly, 10 years later, they put Eliza into conversation with a chatbot that had been developed by a psychiatrist named Perry, who was supposed to imitate the conversational style of someone with a diagnosis of schizophrenia. So a bizarre encounter, and it utterly failed as a kind of effort to mimic human conversation. But what it tells us is something about the involvement of psychology and psychiatry in very early discussions about AI, and the imbuement of conversations about artificial intelligence with those ideas. And those ideas have been sort of pulled apart by previous speakers and some of the power dynamics that go along with those ideas. But today, this is translating to a huge movement of technologies, a huge field of development. Prominent mental health practitioners are saying that it's going to address the global mental health gap, that it'll create radical change and help reach billions of people, given the unconstrained geographic reach and scalability of interventions. Governments have invested millions, and the World Economic Forum had a white paper that sketched out the kind of scale of the market at the moment in these areas. The global digital health market has been valued at $118 billion worldwide, and mental health is one of the fastest growing sectors. Tech startups in the mental health space have seen funding triple in the past 5 years, reaching a record $602 million in 2018. And other market analysts have put the mental health software market at $4,585 million by the end of 2026. Now, all of this would have accelerated greatly under the pandemic conditions as services in health and social services have virtualized and digitized. So we are seeing a huge expansion of these technologies. There are reportedly over 10,000 mental health apps that are now available. So as part of my research as a Mozilla Fellow, I wanted to actually just try to get some empirical basis for some of the concerns that are being raised about the exclusion of people who are from affected populations. So we did a survey of all the empirical research we could find that used AI and other algorithmic technologies in mental health care, and tried to see how many were considering ethical, legal issues, and how many were involving affected populations in the development or even in the most cursory and superficial way. And of 132 empirical papers, we found that only 15% contained even a very brief consideration of ethical issues. I conducted it with this fellow here, Tim Kariotis, whose picture is on the screen, as well as not a single study appearing to involve people with any lived experience of using services or affected populations. So this was some empirical evidence that demonstrated that this is just not happening across the board. And there are exceptions to this. There are some scholars in the area who are engaging with affected populations, and there are some tech developers who are doing this. But as a broad kind of characterization of the field, it's just not happening. So think about all that money and time and resources that I mentioned earlier, all going into efforts that aren't involving the people for whom these technologies are primarily aimed at helping. And I do honestly think engaging beyond consideration of bias and discrimination to the politics of mental health that have been so brilliantly sort of outlined in the last few presentations is the key to stopping data harms arising in the mental health context. And as the digital phenotyping discussion has highlighted too, all of us create data concerning mental health, especially if some of these affect recognition technologies are to be taken seriously in terms of how we swipe, how we type, can reveal about our cognitive state. And the data harms are real, and the data harms are often under discussed. Privacy International and in an initiative led by another former Mozilla Fellow, Frederica Keltuna, have identified that of the 136 popular web pages related to depression in Germany, France, and the UK, that over 97% contain third-party elements that enable targeted advertising. And most failed to meet the EU General Data Protection Regulation, but they simply weren't being enforced. Criminal justice agencies have been shown to breach privacy laws by sharing non-criminal information about the mental health of citizens, which is then used in discriminatory ways. For example, individuals being refused entry by border authorities on the basis of having used mental health services. And in the US, there's some preventive gun violence initiatives by law agencies that seek to link databases about people's engagement with mental health services with their social media content. There are hacking examples of hacking or leaking of confidential records of recipients of health services. This example from a few months ago related to mental health data on a scale affecting tens of thousands of people. Airbnb has patented software that digs through social media to identify people who display narcissism or psychopathy. This kind of AI or machine learning is not necessarily subject to independent monitoring, and there's not consideration, as far as I can tell, certainly not publicly, of the ethical and legal implications affecting people who might be identified in this way. I'd just like to mention some of our fellow members of the sort of discussion panel, the sort of advisory panel that informs some of my work. Leah Harris is someone who might be of interest to people, and who, as far as I can tell, came up with this term, the rise of the digital asylum. There's also Jonah Bosowich, whose work on apps is quite interesting. As well as the work of Sarah Carr, an academic in the UK, who's written an excellent article on AI in the mental health space. So I hope my brief discussion of this area has given people a sense of some of the steps that are being taken and ought to be taken in order to make sure that these issues don't get out of hand. Keris, I'll throw it back to you if that's okay.
Thanks. Yeah. It's so interesting to hear all of us speak together. I hope it was interesting for the audience as well. And I'm always curious, and we really do want to move to action steps, not discussion, but then action steps, because it's nice to hear all of this information, to understand the disparities that happen, with people with disabilities and people who have been given mental health diagnoses. And the question is, what more can we do? What should we be doing? I mean, clearly involving people is what we're saying. And, I could say even more than involvement, but would love to hear, I'm sorry, my camera's off. I don't know what's going on. Okay, would love to hear from folks who are, in attendance with us, kind of how did they receive the information that we presented, as well as what things have they been doing, and or what things do they think, we could be doing to increase participation and leadership from people with lived experience. So I can read some of the comments. If people don't want to speak openly, they can. But so I'm reading, with all of the danger of abuse of mental health data, would you still recommend to step forward with those kind of mental health apps?
This is Lydia. Let me comment briefly on that. Again, I would go back to the point of, does a particular app serve a purpose that people who experience that impact of mental health or mental illness actually want? And if so, then how can you make sure that the people who are using that app have ultimate and as much to complete control as possible over their data, over where it goes, over how it's used? So for example, one thing that I think of as a model for that is the way that apps like Signal work, where Signal messaging doesn't store copies of your data anywhere. And in fact, even if you try to sync your messages from your phone to your computer, if you add a second device, the second device can't even access what the messages are that you've received or sent on your account prior to adding that second device. And something that allows you to enable local storage that does not sync that storage to somewhere else, does not allow anyone to have access to that data, is one important way to protect people's information. But the other one is to make sure that people have clear, easily understandable information about what data is collected, how that data could be used were someone to gain access to their data, and how they can also take steps to protect their own data, and how they can opt out at any single time. But again, that basic model for how to use such an app needing to be an opt-in basis, like you opt to use the app or not. And for any feature that an app might offer, if it's more than one specific feature, can you opt in to each of the features rather than having to find out or figure out how to opt out? And lastly, finding the least invasive possible way of providing the service the app is meant to serve. So for example, there's a very simple tool that I actually link to in my email signature. Let me find the link and I can drop it for you. It is bit.ly/self-care help is the little link that I used for it. I didn't create that. It's a very small self-care tool that anybody can use. It was designed for people that are experiencing difficulties with self-care and executive functioning, often arising from mental health disabilities and other disabilities. And it doesn't collect people's data as far as I'm aware. I could be wrong in making that up. But it doesn't require tracking a particular person. If you open it anew, it's a completely new session every time. You don't even have to have an account to use it. It's just a freely available service. So it provides a particular service with very minimal collection of any information about a person using it at all, let alone information that could be potentially identifiable, but that your internet history might show that you've been to the website. And when you're thinking about building an app, I ask that, right? Like, simple is sometimes the way to go. Does it need to have 20 million different features? Does it have to collect 20 million different data points when 3 data points would have been fine for the purpose that it's serving? And I would just echo Kelechi's comment in the chat too. She wrote, that's why we've been uplifting digital mental health literacy to make sure that consumers, quote unquote, can have agency and choice over what's happening with their data.
Yeah, and I'm going to add one other thing that's really great is thinking about the first time I used a mental health app. My provider didn't know how to use it. My family didn't know how to use it. And I kind of taught myself how to understand it and use it. And then when something came up, my provider said, well, gee, we're doing kind of better 3 weeks ago or for whatever it was. And I was able to kind of go back to the app, look at it, show it to him, say, well, this is this, this is that, this is the other. So that it actually became quite a useful tool. And it helped me also understand some things to quote unquote calibrate for myself that the app couldn't tell me. Like the app kept saying, well, if you're at a 10, it appeared you're doing well, but I kept getting at a 5. But for what I found out for me is like 5 actually is really, really good for me rather than me trying to kind of reach up to this 10. And so I think that, also thinking about kind of, how can people utilize some of these applications when and how they need them and put them away when they're done. The other thing that's happening is that and I think Lydia, you spoke to this, is that there's the medicalization, kind of the app is now the new pill, meaning I'm going to prescribe an app to you. And if you don't use this app as prescribed, then you're being kind of, non-compliant. And it's not a pill. I mean, people use apps, they download them, they stop using them. That's what people do. And guess what? We're people just like anybody else. So I think those are some of the things to think about. Somebody did ask about some, and I think Lydia gave an example of, apps that are secure and privacy focused. What's really, really interesting, and I wouldn't have necessarily thought of this at the beginning, but the Veterans Administration in the US has a bunch of apps. And the cool thing about the VA apps is they do have evidence behind them. And they are privacy focused because the VA doesn't want that information because they are a government entity. So there are things about, our personal health they're not supposed to have. And so they have one of the most elegant privacy statements and thoughts about how to protect your privacy, who owns your data and who doesn't. So I sometimes lift that up as an example, even though it might seem a little oxymoronic because it's the VA.
I could just jump in on the apps. I've come across 2 recent studies that found that of the popular mental health apps, just under half of those surveyed had a privacy policy that informed users about how and when personal information would be collected. So I would say if it doesn't have good policies that you could check yourself or with these other kind of ways of verifying it, I wouldn't be using it. But there are good examples out there that I've heard about. I don't know them myself, but people certainly have sort of said that they've got a great deal out of them. Another really interesting survey I've come across, just to jump off Keris's point about medicalization, is one that did a survey of the messaging in mental health apps and found that most of them unduly medicalized states of distress and anguish and so on, And that goes to the point about the tendency in some of this technology to amplify the medicalization of distress, when other ways of talking about anguish and anxiety and, you know, social concerns and so on are maybe more appropriate. I see that Anjali's, oh, sorry, go ahead, Kelechi.
I would just hop in and say that one resource you might want to look at is Cyber Guide. What they do is actually look at digital health resources, and they have reviews of them. And you know, they look at things like transparency or professional reviews or creatability and user experience. I'm always encouraging more lived experience in that part, but having things like, you know, checking out if there is like, oh wait, no legalese, or we don't know what's happening or what's not happening. So that's definitely one resource I've used to check out an app to see if I should download it at all. And I know we're at time.
Yeah, the APA has a similar one, in the APA American Psychiatric Association, which might make people go, oh, wait, what? But there are peers involved in their app evaluation, which I really appreciate, because it's psychiatrists, nurses, social workers, peers, and family advocates. So it's a whole group of people. And the thing that I really appreciate about it is that not only is it a group of people that are involved, but we've been able to teach people, to show them, look, print out that privacy statement and tell me what you get. You get 18 pages plus links plus the, so it's really helping teach people who wouldn't have thought of looking at it this way, of looking at it a new way. So it's really powerful stuff. So I know we're at time. Hopefully we can respond to any other questions following, and really want to thank everyone for attending the session and participating. I'd like to thank peers for putting together this panel, and for the panelists, myself, Kelechi, and Lydia, bowing down before each of you and wearing my lovely shirt, Black Nerds Unite, but we all unite in this sucker. So thank you very much for attending.
Thanks, everyone.
Thank you, guys.